So, welcome everyone. Again, my name is Ahmed Gamal Sharif. I'm currently working as a PICU consultant uh, in Royal Stoke University Hospital, following University Hospital of North Midlands, and with the Birmingham Children's Hospitals as well, as part of the kids transport team as well. And I'm going to talk today about non-invasive neuromonitoring in pediatrics. Okay. So, what are the objectives that I'm going to try to cover? So, I'm going to try to cover the familiarity with the different modalities that we use in pediatric intensive care, what each modality is used for, and what is the evidence base behind each of these modalities. So, neuromonitoring starts basically as a main message with the standard neurological examination. So, just to be sure that while we're talking about technology and modalities that we're going to be using by the bedside, that you need to always remember that neuromonitoring always starts with the standard neurological examination. The problem is it's unfortunately lagging behind pathological progression. So by the time you pick up a change in the clinical condition, there might have been already injury that caused that change, which is why we need neuromonitoring. So we have different types of neuromonitoring. We have invasive ways to to keep an eye on the insides around the brain, like having intracranial pressure measurement bolts, or how we call it ICP bolts. We can measure brain tissue oxygenation directly, invasively as well. And there are other advanced stuff that I'm not going to touch base on because we can keep going forward with lots of different modalities. So we're not going to talk about the invasive ones today. Today, we're going to talk mainly about the non-invasive modalities, like the EEG, CFM, transcranial Dopplers, and others. And then we have a different way also to classify neuromonitoring. We have continuous neuromonitoring. Again, that can be ICP monitoring invasively or can be non-invasive like CFM. We have intermittent neuromonitoring modalities like transcranial colored Dopplers, evoked responses, and standard EEG. Okay. So if we go with the classification of neuromonitoring, we have also different classifications according to how we deliver the neuromonitoring. So we have electrophysiology that can be one of two categories, like spontaneous nerve activity, like what we monitor with EEG, CFM, and EMG, or evoked responses, which come from the brainstem, and that is measured with different stuff that we don't usually use every day and every night, but can be useful when we're trying to identify brainstem death, like SSEPs and BAEPs and visual evoked potentials as well, and all of that. While if we go away from the electrophysiology for a bit, we can also try to assess neurological function using hemodynamic and oxygenation assessments, and we can do that with transcranial Dopplers or near infrared spectroscopy or NIRS. Intracranial pressure can be assessed invasively, as we said, or again non-invasively by transcranial Dopplers or transcranial colored Dopplers or optic sheath diameter. And we have also biomarkers that can help us assess the function of the brain. These are things that are being assessed now in pediatric practice, but have been well established in adult practice, which is the neurospecific enolase (NSE). Okay, so let's start talking about common stuff. Let's talk about things that we actually might be seeing in our practice. So common non-invasive neuromonitoring modalities will definitely start with we saying EEG. What's the commonest EEG? But EEG doesn't come in one flavor. There's the standard EEG that you see in clinics and in standard practice. And then we have the CEEG and the QEEG, and I'm going to talk about them. And we have the CFM, or cerebral function augmented monitoring. Okay. So what do they all do? They're all EEG basically, which means they all measure the electric activity in the brain. And according to that measurement, they can detect seizure activity and patterns of encephalopathy. We like CEEG, which is continuous EEG. So the C is continuous. Continuous EEG is preferred in ICU setting because it's basically continuous. It can measure change that happens at any time during the patient care. But if you add qualitative EEG, so the Q is qualitative, if you add qualitative EEG to what you're doing, that can also add more information about what you're dealing with in advanced cases. So CFM, and that's why we have a special talk about CFM, is actually a combination of continuous EEG and qualitative EEG monitoring, which we like nowadays to use in ICU. The best thing about it is that it's cheap. So it's cheap modality, very useful. It provides continuous brain monitoring and analysis of electrical activity. It allows also for you to see things real time as they happen. So if something is happening now, you can see. If you're giving anti-epileptic, you can see if actually it settled the seizures or not. If the patient status changes from being encephalopathic to being more active or the other way around, you can see it real time. So it's very useful. Okay, and that's why we like CFAM nowadays in PICU. So what do we mean, like in pragmatic approach when we look at them? Which one is CFM? Which one is EEG? So on your left is a qualitative EEG. You can see the number of channels, very like so many channels. You can't read that day to day by the bedside and expect the nurse by the bedside to see it and tell you, oh, something has changed, or one of your juniors or whatever. While on the right hand side you have a CFM monitoring, so it's all augmented into just two channels, and that helps with you seeing what you're dealing with. And it's very easy at this point to identify that this is different to the rest of it. So this is a suspicious seizure, or maybe it was also, if someone can put a marker, maybe someone was just delivering care or moving the patient. But there is something that changed here that you can easily identify. It doesn't need someone with high level of training to know that this is a change. Okay. And the simplicity goes on because with CFM you have only a certain number of uh, waveforms that you will see, and these waveforms will tell you what you're dealing with generally. It's not very detailed, but you can call it a screening method, but it's real time by the bedside. That will help you to ask for detailed EEG on time, and will help you to also identify seizures really quickly and titrate your treatment. Without going much into details, that we have a certain talk about CFM, but this is normal. This is a bit abnormal, but still acceptable. So a bit encephalopathic, but can be reversible. This is what we call low voltage. So again, this means encephalopathy, but in a very higher level than in comparison. So this is a bit scary. This is the flat trace that is really scary because it might be a precursor of brain death. So if it's not reversible, then that is pushing for discussion about having evoked potentials and evoked responses to assess brain death. This is burst suppression. So burst suppression can be either something that happened to the patient again as part of their encephalopathy, or you can have burst suppression being caused by medicine. Like you can actually start burst suppression yourself using thiopental coma or phenobarb coma or propofol. And then you've got status epilepticus, as you can see here. And if you have just one small run of those, that's just seizures. Okay? And this is basically the number of waveforms that you're going to see with CFAM. The next one we're going to talk about now, after we talked about the cluster of EEG and CFM and all of that, is NIRS. So NIRS, we have again one talk about NIRS on the channel, but it's in Arabic. So NIRS estimates brain tissue oxygenation using relative absorption of oxygenated and non-oxygenated hemoglobin to get cerebral oximetry values. Basically, it's like the pulse oximetry or the SATS probe, but for your brain. Currently, up till now, despite years and years and years of using NIRS, in different units in different places, there are no established thresholds for NIRS values that you can actually call normal versus abnormal, and you can't really have certain action being done just because of a NIRS number. So if NIRS is reading 60s or 70s or 80s, independently, that doesn't really mean anything. But the value of NIRS is higher when you're using it for CPR during cardiac arrest, because it shows you if the brain is getting better perfusion versus worse perfusion. And that has been linked to higher rates of recovery and better survival to discharge. Also, you can use NIRS from trends point of view to know if your trends are getting better or getting worse, but you can't use single numbers or single readings to just go forward or backwards with NIRS. If someone has got a different opinion or different experience, please put it in the chat. And this is just to highlight what NIRS is. So basically, it's like a patch. One bit of that patch is sending waves, and the other one is picking the waves. And so this is emitting, and this is detector. You have surface detector and deep detector, and because of the difference, you can tell, or your machine can read the saturations. There are some challenges because when you look at that, it's really relying on the thickness of the layers between the skin surface and the brain. So if it's a child with a lot of hair or a child with thick skin or edema, that can change the readings. Also, it's very localized. It's very localized to a certain area. It's not really covering the whole brain. So if you've got regional differences, let's say this place is a bit ischemic and this place is well oxygenated, you're going to be reading the better oxygenation readings and not the less ischemic readings here. So you're going to possibly miss focal changes, which are the difficulties or the weaknesses of NIRS. Okay. Next, we're going to talk about transcranial Dopplers and transcranial colored Dopplers. What do we do with these? These are modalities using the Doppler waves to calculate flow velocities in your cerebral arteries. And we mainly rely on the middle cerebral artery and anterior cerebral artery in our cohort of children. We use the waves and we use the readings of the flow velocities to calculate pulsatility index to differentiate between systolic and diastolic and velocities in the middle cerebral artery or the anterior cerebral artery. And the PI itself as a reading, or the pulsatility index, has been used and proven to have good correlation with ICP readings and CPP readings in a non-invasive way. We also can use resistive indices in children to confirm diagnoses or to prognosticate diagnosis of hypoxic ischemic injuries and also of increased intracranial pressure. We've been using transcranial Doppler and transcranial color Dopplers in children with TBI, intracranial hypertension, vascular vasospasm and stroke, cerebrovascular disorders, and sickle cell disease, actually, CNS infection and ECMO, with very promising, science coming behind it and evidence base to support it. There's a big group of centers now using it specifically for children on ECMO as well. And this is just to give you a hint of it. So this is transcranial colored Dopplers, which means you are looking with your eyes to assess the vessels and to assess the image that you can see and to look at the waveforms and get your measurements. So usually when we're looking from the temporal window, so any child with closed anterior fontanelle, we look from the temporal window, and the first vessel in front of you from the circle of Willis would be the MCA, or the middle cerebral artery. So if you're looking from the right, it's going to be the right middle cerebral artery. If you're looking from the left, you can measure the left middle cerebral artery. Don't measure the left middle cerebral artery from the right side. That's not the right way to do it. You need to measure the closest and most straight vessel in front of you. And these are the waveforms you're going to get from it. Then if you try to get some reading from the anterior cerebral artery while you're not lined up with it, you're going to have it going bidirectional. And as you go further, it's going to be actually going away from you. But anyway, there are different waves, different ways to see it, different measurements to do it. But it's very useful. And then if the child has got an open anterior fontanelle, you can actually look at the anterior cerebral artery and look at the vessels while you're doing your cranial ultrasound from the anterior fontanelle and get your measurements as well. And this is the transcranial Doppler probe that they use in adults. There are similar straps for children, and that's not going to give you a visual. That's relying on the sound waves itself that come from the Doppler. So it's basically going to give you waveforms here, but it's not going to show you vessels. It's not going to show you anything. It's a bit tricky because you need to align it really well. So with children, if they move, it's really hard. It also gets really hot with time, but it's more continuous than color Dopplers, because color Dopplers means that you're going to keep coming and going to assess and measure, while this can be just put on the patient and it can keep the reading going. And you can see actually how valuable transcranial Doppler waveforms are to give you an understanding of your patient. So these are normal waves. Then if the intracranial pressure starts going up, you can see that the diastolic pressure goes down and starts blunting, as we call it. Then as the intracranial pressure goes higher than the diastolic blood pressure completely, so if the intracranial pressure in the brain, around the brain, is higher than the diastolic blood pressure, then there's not going to be any blood flow during diastole. And then with time, actually, there's going to be a reversal of flow, which is very bad. That means your ICP is now equal to your mean arterial pressure. And this is what we call circulatory collapse, because you can see that the reversal of flow is going to be equal to the forward flow with systole itself. And the systolic flow is also diminishing. And then at some point, you're going to get either you might get mortality around this or brain death, or you can have a vasospastic event that will have waves that would be going very high with your vascular system to overcome the vasospasm itself. So the vasospasm causes higher pressures with high velocity, but actually it's not adequate blood flow. It's like basically you're pressing the hose of the water, and the water is going with high pressure and high flow. It doesn't mean that you've got more water going. Okay. Next, we have something that is also coming into fashion now, which is called optic nerve sheath diameter readings using ultrasound. So one of the ways that you would be assessing for increased intracranial pressure is looking at your optic disc, right? So you look with your lens through the patient's eye and try to look at the optic disc, which is really hard. So nowadays we're trying to use ultrasound to actually get that picture and to measure the optic nerve sheath diameter, and using that reading or using that measurement, we're trying to non-invasively assess for increased intracranial pressure. And it's indicated up to now with the readings that we've got from adult evidence base as anything that is greater than 5 millimeters would be taken forward as a sign of increased intracranial pressure. It is also dependent on proper technique, and it's very dependent on the person doing it, because the measurement relies on you taking it in the right place and the right length and right depth of where you're measuring. So if the person doing it is not very well trained, then you can have wrong readings and wrong interpretation, and that's possibly the cautious part about optic nerve sheath diameter for the minute. We need standardization of readings for children, and we need good training for people before we start interpreting what they're saying. So I wouldn't recommend it up till now to replace ICP monitoring, but it is emerging, and at some point it will be recommended in every practice at some point. So to give you a picture, this is how it looks. So you basically apply the probe on the upper eyelid while the patient is looking down, or if the patient is sedated, just try to be as upwards as you can with the eyelid. Again, the probe can get really hot for the eye, and you don't want to cause damage. This is just telling you what structures you're dealing with, starting from the cornea to the anterior chamber to the lens to the vitreous, back to the retina and the optic nerve. And then what you try to do is go down 3 millimeters from where the optic disc starts into the optic nerve itself, and you take the widest two bits with the dark hypoechoic lines here, and that will give you your optic nerve sheath diameter. If you go internal, like here, that's going to be your optic nerve itself, not the optic nerve sheath. Two different things. Okay? Okay. So these are the most common non-invasive monitoring modalities that I can tell you about without burning your brain cells. The question is, what should we use? What should I get to my unit? What should I rely on? Well, ideally, what we recommend is something called multimodal neuromonitoring. So you should actually have more than one mode. You should have something that covers for blood flow, something that covers for oxygenation of the brain, something that covers for electrophysiology, etc., etc. You should have something that represents every part, but sometimes that's difficult. So you need to work on your own unit wherever you are, according to the budget you have, according to what's cheaper and what's actually more common out of your patient that you see and you want to deal with, and accordingly have the modality that you're going to use in your unit. Okay? I'm happy for any questions. Thank you very much. I'm going